welcome to the deep dive. You asked, and today we're really getting into a critical eye condition, endophthalmitis. Think of this as your focused high-yield guide for revision.
Exactly. We're diving into endophthalmitis, and at its core, it's basically a severe inflammation inside the eye. We're talking the inner tissues, the vitreous humor, that gel stuff, and the retina, the light-sensitive bit at the back. The crucial thing, really, is that it's almost always caused by an infection.
And it needs immediate attention, right, to save sight.
Absolutely. Immediate medical attention is key.
So our mission today is to give you a clear, hopefully memorable framework, covering everything from the definition to complications. And we'll try to drop in some memory aids along the way for your exams.
Yeah, good plan. We're using a pretty comprehensive medical overview as our base for this. So let's start with that definition again, just to nail it down. Endophthalmitis, severe inflammation, intraocular tissues, vitreous, retina, and overwhelmingly, it's infection-driven.
And I think we need to stress the urgency again. It's so critical.
Totally. Burn this into your brain. It is sight-threatening. An emergency needs swift action.
Swift action for the best chance of saving vision.
Precisely. So let's think about etiology, the causes. Mostly, the main cause is bacterial infection. Usually gets in after surgery or some kind of penetrating trauma to the eye.
Okay, so bacteria after surgery or injury, those are the main pathways. Are there less common causes too?
Yeah, less often you might see it caused by fungal infections or even viral ones. They're not as common, but definitely something to keep in the back of your mind, especially in, certain situations.
Got it. Bacteria are the usual suspects, but fungi and viruses are possibilities. Now, who's actually more likely to get this? Let's talk risk factors.
Right, risk factors. There are several important ones. A big one is recent intraocular surgery.
Like cataract surgery.
Exactly, particularly things like cataract surgery where you're physically going inside the eye. It just creates a potential opening for infection.
Makes sense. Breaching the eye's defenses. What else?
Open globe injuries. So when the eye itself has been pierced or ruptured, that's high risk. Also, if there's a foreign body stuck inside the eye, especially if it's organic material, things like wood splinters, plant matter, that really ups the risk.
Ooh, yeah. That sounds like a perfect setup for infection. What about existing eye problems? Can they increase risk?
Yes, definitely. Certain conditions on the surface of the eye, like corneal ulcers, can make someone more susceptible. And kind of broadly, anyone whose immune system is compromised is at higher risk too, whatever the reason for that might be.
And things during surgery itself, could that be a factor?
Absolutely. Unfortunately, yes. Poor surgical technique, maybe a contaminated intraocular lens implant. These can introduce infection. And thinking outside of surgery, just poor hygiene with contact lenses, that's a risk factor too. Oh, and chronic corneal ulcers, we should mention those again.
So it's about injury, surgery, but also ongoing eye health and hygiene. What about general health, systemic issues?
Yeah, several systemic things can increase the risk. Just being in a generally weakened state, debilitated. Or having an infection elsewhere in the body that could potentially spread to the eye, maybe from an indwelling catheter, for instance.
Oh, so it can come from within the body too.
It can. That's endogenous endophthalmitis. Also, any cause of immunosuppression, maybe conditions like AIDS or people using intravenous drugs, and diabetes is another big one.
Wow, okay. It's quite a range of factors. So we know who might be at risk and how it might start. Let's get into the pathophysiology. What's actually happening inside the eye?
Okay, so basically microorganisms, usually bacteria, sometimes fungi or viruses, they get inside the eye, they invade the tissues. And this invasion kicks off a really strong inflammatory response inside the eye.
And it's that inflammation plus maybe toxins from the bugs that causes the damage.
Exactly that. The toxins released by the microbes plus the body's own immune response trying to fight it. It all leads to significant tissue damage. And that's what disrupts how the eye works and leads to vision loss.
You mentioned the blood-ocular barrier earlier. How does that fit in?
Right. So normally this barrier, it's made of tight connections between cells in the blood vessels of the retina. It acts like a shield. It usually stops pathogens getting from the bloodstream into the eye easily.
But it can be broken down.
Yes. Surgery, trauma, or sometimes in severe systemic infections, the bugs can overwhelm or bypass that barrier.
Okay, so barrier breached, infection takes hold. Our overview mentioned different types. Can you just quickly list those again?
Sure. We tend to classify it based on how it started. So you've got postoperative.
After surgery.
Right. Traumatic.
After injury.
Endogenous.
Spreading from elsewhere in the body.
Exactly. Then there's endophthalmitis linked to corneal infections, some related to intravitreal injections into the eye, and also Bleb-associated, which is a complication sometimes seen after certain glaucoma surgeries.
Okay, that's a helpful way to categorize them.
Mm-hmm.
And the actual bugs, the specific microorganisms we should know.
Well, it can vary a bit depending on the cause, but some key bacterial players are coagulus-negative staph, streptococci, and one to really remember is Bacillus cereus.
Why that one specifically?
Bacillus cereus is notorious for causing a very, very aggressive, rapidly destructive form of endophthalmitis, so definitely flag that one in your memory.
Bacillus cereus.
Oh!
Aggressive. Got it.
Other common ones include Staphylococcus aureus, Klebsiella pneumonia, and on the fungal side, Candida species are pretty common.
Okay, now differential diagnosis. If someone comes in with these symptoms, what else could it be?
Good question. It's really important to differentiate it. You need to think about other things causing inflammation inside the eye. So uveitis, which is a more general term for intraocular inflammation and other infections specifically affecting the back part of the eye, the posterior segment, they need ruling out.
Other inflammation and infections at the back of the eye. Anything else?
You also have to consider non-infectious inflammatory conditions. Sometimes they can look quite similar initially.
Right, so careful examination is key. How common is this condition, say, in the UK? What's the epidemiology like?
Thankfully, it's pretty rare overall,
Okay.
but its incidence is definitely linked to how much intraocular surgery is being done.
And for something common like cataract surgery, do we have numbers?
Yeah, for cataract surgery, the reported rate is somewhere between about 0.1% and 0.3%.
So not high percentage-wise.
No, but because so much cataract surgery is performed, it still represents a significant number of cases and a major concern in ophthalmology.
Right, volume makes it significant.
Oh.
Okay, let's move to clinical features. What does the patient experience? What signs do we look for?
Okay, symptoms. There's a handy mnemonic here. Think pride.
Pride. Okay, another mnemonic. Let's break it down. P is for?
P is for severe eye pain. R is redness. That's the conjunctival injection. The white part looks red and inflamed.
Okay, pain, redness.
I is impaired vision, a noticeable drop in how well they can see. D is discharge from the eye, or maybe eyelid swelling. We can cheat a bit and use swelling for D too if it helps remember discharge or swelling.
Okay, pain, redness, impaired vision, discharge or swelling.
E. And E is for corneal edema, swelling of the cornea, the clear front part of the eye.
Pride. Pain, redness, impaired vision, discharge, swelling, edema. That's really useful. Are there other really key signs you'd look for on examination?
Yes, absolutely. A classic hallmark sign is hypopyon.
Hypopyon.
That's pus in the anterior chamber, the space between the iris and the cornea. You'll see it as a layer of white or yellowish fluid settled at the bottom.
Okay, pus in the front chamber. Definitely a red flag.
Huge red flag. You'd also look for vitreous haze. The vitreous gel inside the eye becomes cloudy, murky, like smoke in there. And signs of retinal inflammation when you look at the back of the eye, the fundus.
Hypopyon, vitreous haze, critical signs.
Yeah,
Do the features change much depending on the type, like exogenous versus endogenous?
there can be variations. For exogenous, from outside, like surgery or trauma, the onset is usually pretty acute. Rapid pain, rapid vision loss. You might see eyelid swelling. Hypopyon is common. But importantly, they usually don't have systemic signs like a fever or high white cell count. It's typically localized to the eye.
Okay, mostly eye symptoms in exogenous.
Yeah.
What about specifically after surgery? Acute postoperative.
Right. Acute postoperative usually hits within the first week or two after the operation. It's sudden, severe vision loss, pain, redness, maybe discharge on examination. Lid edema, conjunctival injection, corneal edema, definitely hypopyon, and lots of inflammation in both the anterior chamber and the vitreous. It looks angry.
Sounds dramatic. And the delayed postoperative type.
That comes on later, maybe around 9 months post-op. Sometimes longer, it's more gradual. Vision slowly gets worse, eye gets redder over time. You'll still see signs like conjunctival injection, maybe hypopyon, but also characteristic clumps of inflammatory stuff, exudates. The cornea might look cloudy. The timeline is the big clue here.
Slower onset. And Bleb-associated after glaucoma surgery.
That one tends to worsen rapidly. Fast onset of pain, vision loss, redness. A key sign can be the bleb itself looking milky white. Hypopyon might be there too.
Okay. What about non-surgical? Traumatic endophthalmitis?
Similar symptoms to the acute postoperative usually. But in really severe trauma cases, you might get systemic signs, fever, high white count. You could also potentially see proptosis, the eye bulging forward, or even a corneal abscess developing.
Right, potential for systemic signs with severe trauma and endogenous bacterial spreading from inside the body.
Yeah, typically in people who are immunocompromised or IV drug users, they might present with lid and conjunctival swelling, cloudy cornea, maybe little hemorrhages on the retina, and hypopyon is common. The bugs are often things like Staph aureus, Strep pneumo or viridans, E. coli.
And Candida endophthalmitis.
This one can sometimes affect both eyes, seen with systemic candida infections or after penetrating injury. Our source didn't specifically link it to AIDS, interestingly. Patients might notice decreased vision, floaters, and the characteristic sign is these yellow-white fluffy lesions on the retina, along with widespread inflammation.
Those yellow-white lesions sound quite distinct. Any others?
Other fungal types are rarer, but maybe increasing, often linked to IV drug use, chemo, immunosuppression. Presentation can be similar.
And finally, when it follows a corneal infection.
Yeah, sometimes a really bad corneal infection, microbial keratitis, can just progress deeper into the eye, so you'd see the severe corneal signs plus all the intraocular inflammation signs.
Okay, quite a spectrum of presentations. Yeah. So how do we actually diagnose this? What are the key investigations needed?
Well, the first thing, absolutely fundamental, is a detailed eye exam, using the slit lamp for the front of the eye and fundoscopy to look right at the back retina, optic nerve.
Standard eye exam tools. Crucial first steps. Imaging.
Yeah, OCT optical coherence tomography can be useful. It gives really detailed cross-section pictures of the retina and other structures, helps assess the extent. But the really definitive thing, the test that confirms it and tells you what bug is causing it, involves getting a sample from inside the eye.
Okay, how do you get that sample?
Usually with a vitreous tap. A fine needle is used to carefully draw out a small amount of the vitreous fluid. That sample goes straight to the lab for culture and sensitivity testing. Identify the bug, see what kills it.
Makes sense. Culture is key.
Sometimes a diagnostic vitrectomy surgery is done, more vitreous is removed, which can be both diagnostic, providing a larger sample, and therapeutic.
Right. Identifying the specific organism guides treatment. What if you suspect it's endogenous or maybe fungal, like Candida?
Good point. In those cases, you need a broader infection workup. That means blood cultures, definitely. And if the patient has any lines or catheters, then you'd culture those too, trying to find the original source of the infection elsewhere in the body.
Trace it back. Makes sense. Other lab tests?
PCR polymerase chain reaction on the vitreous sample can be helpful. It can sometimes detect bacterial or fungal DNA faster than culture, or if culture is negative, maybe blood tests like ESR or creatinine just to check for systemic inflammation or kidney issues. And occasionally you might need a CT or MRI scan of the orbit, maybe to rule out other things or see how far the infection has spread.
Okay, quite a thorough workup potentially.
Yeah.
Once you have the diagnosis, how is endophthalmitis managed? What's the treatment?
Right, management. The absolute cornerstone is immediate treatment with antibiotics or antifungals. These are usually given intravitreally injected directly into the eye and sometimes systemically too, depending on the situation.
Direct injection into the eye. Wow.
Yes, that vitreous tap we mentioned for diagnosis, it's often immediately followed by injecting the medication right into the vitreous cavity. Gets a high concentration of the drug straight to the infection site fast.
Very direct. Is surgery always needed?
Not always, but often, especially in severe cases. Or if things aren't improving quickly with the injections alone. A pars planivitrectomy might be performed. That's surgery to remove the infected vitreous gel, clearing out the bugs, the inflammatory cells, the toxins.
So, targeted drugs, sometimes surgery. What's the prognosis like? The outcome?
It's really variable, unfortunately. Depends heavily on a few things. What organism is causing it? Some are much nastier than others. Also depends on the original cause, how quickly treatment was started, and how much damage was already done before treatment began.
But the key message is that speed matters.
Hugely. Early diagnosis, prompt treatment. That significantly improves the odds of saving useful vision. Delay is really bad news for the eye.
So recognizing pride early is vital. What are the potential complications if things don't go well?
They can be really severe, potentially blinding. We're talking significant permanent vision loss, retinal detachment, scarring of the macula, which ruins central vision. You can also get secondary glaucoma, cataract formation.
Sounds devastating. Any worse outcomes?
In the absolute worst case scenarios, if the infection is just overwhelming and can't be controlled, Enucleation surgical removal of the entire eye might be necessary,
Wow.
primarily to stop the infection potentially spreading outside the eye, which is very dangerous.
A drastic step. But you said timely treatment helps avoid this.
Yes, absolutely. Effective, prompt management massively reduces the chance of these really bad complications. That's the critical take-home point.
Okay, let's quickly summarize the absolute key points for revision. Endophthalmitis, severe eye infection, needs immediate action. Remember, pride for symptoms, pain, redness, impaired vision, discharge swelling, edema.
And look for a hypopoc vitreous haze.
Diagnosis often needs a vitreous tap for culture. Treatment is urgent. Intravitreal antibiotics or antifungals, maybe vitrectomy surgery.
Exactly. Early treatment is everything for improving the prognosis and cutting the risk of those serious complications. Hopefully, yeah, this has given you a clear, structured way to think about endophthalmitis for your revision.
Definitely. And maybe a final thought for everyone listening to chew on. With more eye surgeries happening and the worry about antibiotic resistance growing, how might that change things for endophthalmitis in the future? Its frequency, how we treat it, something to consider.
That's a really important point. And of course, if you're looking for more revision materials, practice questions, really solidifying this stuff, don't forget to check out passthemsra.com and freemsra.com as well. Great resources there.
Excellent. Well, thanks for joining us on this deep dive into endophthalmitis. We'll catch you on the next one.